for another round of bleeding disorders. In our last sketch, we talked about platelet disorders that cause bleeding. This time, we're still bleeding, but it's all about those clotting factors. As the sketch progresses, we'll group these conditions according to the portion of the coagulation cascade they affect. For the extrinsic pathway, we'll encounter vitamin K deficiency and warfarin. For the intrinsic pathway, get ready for some hemophilia. And finally, for the common pathway, we'll meet DIC and liver disease. And to remind you that we're killing clotting factors here, we've hung this obligatory kill factor movie poster on the wall of this game room.
If it bleeds, we can kill it.
Just reeking with pubescence. Anyways, before we get bogged down with specifics, let's just relax for a bit. Take in that adolescent stank and review the relevant physiology of blood clotting. First thing to keep in mind is that the liver plays a central role in production of coagulation factors. So we've added a liver shape back there.
Come on, get to the liver. Yay.
The coagulation cascade. All those arrows and numerals and dotted lines. So elegant, so Roman, so numerally. Let's break it down for that 15 to 24-year-old demographic, shall we? The extrinsic coagulation pathway is normally kicked off by exposed tissue factor at the site of vascular injury, represented by the torn piece of poster outside of that toy box, extrinsic, if you will. This exposed tissue factor activates factor 7 to form a tissue factor 7A complex. Factor 7 is symbolized by the 7 deadly sins devil. You might recognize this symbol from the sketchy farm warfarin sketch, where factor 7 was symbolized by the clotting fighter from the 7 deadly sins brigade. If you don't recognize the reference, I'd definitely check out the warfarin sketch. It's a bona fide classic of American cinema. This tissue factor 7A complex then activates factor 10, which is the beginning of the common pathway. And in this scene, just a common fox, a factor 10 fox, if you will. Recognize him? This furry factor starred in our heparin sketch, also way back in Sketchy Farm. So much nostalgia. Let's check out the goodies inside the toy box, representing the intrinsic pathway, which includes factors 12, 11, 9, and 8. It starts with the activation of factor 12, represented by this little army figure with the Roman numeral 10 and 2 guns. This activates factor 11, represented by the 10 army figure with 1 gun. This is followed by activation of factor 9, represented by the 9 lives cat, which complexes with factor 8, the 8 ball, to activate factor 10, thus activating the common pathway. Yep, that factor 10 fox is where the intrinsic and extrinsic pathways converge. Now, these two pathways aren't completely isolated from each other. The tissue factor 7 complex from the extrinsic pathway, for example, also activates factor 9 inside the box, part of the intrinsic pathway. It's just one big happy coagulation family. Now let's focus on the common pathway, starting with that factor 10 fox, which was activated by both the intrinsic and extrinsic pathways. Activated factor 10 gets together with cofactor 5, the toy soldier with the V on his chest. Together, they convert prothrombin, or factor 2, to thrombin, or factor 2A, represented by our recurring thrombin thrombeaver symbol. Thrombin converts fibrinogen, or factor 1, to fibrin, or factor 1A. Cross-linked fibrin is represented by these fibrous crossed toothpicks. Cross-linked with the help of factor 13, of course, represented by this soldier with the X on his chest, as well as 3 extra guns. Alright, now that we've reviewed how the clotting cascade is supposed to work, let's talk about what happens when these factors are dysfunctional or deficient, starting with the clinical presentation. Spoiler alert, bleeding. First, think back to the platelet disorder type bleeding we saw at the platelets home game.
There's no bleeding in baseball.
We saw some asymptomatic petechiae, maybe some small superficial ecchymoses that didn't spread to deeper tissues or anything, maybe some menorrhagia for sure. But now look at Dutch over here.
I ain't got time to bruise.
Patients with coagulation disorders due to factor problems may present with easy bruising and large palpable ecchymoses, as evidenced by this bruise commando covered in large palpable splotches of ecchymotic mud. As opposed to platelet disorders, patients with coagulation disorders are more likely to develop deep soft tissue hematomas, which can present with pain and swelling. Though keep in mind that the differential diagnosis also includes the presence of an obscenely large knife lodged in the leg. Just saying. Hemarthrosis, or bleeding into the joint space, can occur causing joint pain. This typically indicates a severe inherited coagulation disorder, such as hemophilia. Coagulation disorders are also associated with frequent epistaxis and gingival bleeding following minor trauma or dental procedures. Also assess for a history of heavy periods, melena, hematochezia, hematemesis, hemoptysis, or hematuria. All the hemes, really. Spontaneous or post traumatic intracranial hemorrhage is a rare but potentially fatal complication of coagulation disorders. Patients will present with neurologic deficits, headaches, and or altered mental status. Because normal platelet function still allows for the formation of a platelet plug, coagulation disorders may present with delayed bleeding several hours following trauma or an invasive procedure, for example. All right, physical exam time. At this point, we're kind of just inspecting for all the subjective symptoms and signs we already asked about. Look for bruising, soft tissue swelling, gingival bleeding, and neurologic exam abnormalities, including altered mental status or focal deficits. The neuro exam is incredibly important as intracerebral hemorrhage can be quickly debilitating or fatal. And time is of the essence for saving these patients. If you suspect that your patient has a coagulation disorder, get a CBC and check that hemoglobin and hematocrit to look for anemia, which could indicate chronic bleeding that might not otherwise be clinically obvious. Next, get coagulation studies, including PT and APTT, which will help you evaluate the integrity of the clotting cascade. A prolonged PT with a normal APTT indicates a problem with the extrinsic pathway, as represented by our PT paratrooper on the extrinsic side of the poster. PT measures overall speed of the extrinsic and common pathways after exposure to tissue factor. A related test is the International Normalized Ratio, or INR, which is actually the ratio of measured PT over the control PT for the lab, giving us a standardized measurement of the extrinsic pathway integrity. As we'll illustrate underneath this PT paratrooper, a prolonged PT with normal APTT is seen in the setting of vitamin K deficiency and warfarin administration. A prolonged APTT with a normal PT indicates a problem with the intrinsic pathway. These conditions will be illustrated next to the PTT machine gun noise on the left or intrinsic side of the poster. A prolonged APTT with normal PT is seen in the setting of factor VIII deficiency, as seen in hemophilia A and von Willebrand disease, or factor IX deficiency, as seen in hemophilia B. Heparin also typically prolongs the APTT only. Technically, heparin affects thrombin, part of the common pathway, but most PT reagents contain heparin binding chemicals that block its effects. If both the PT and APT are prolonged, there are a few possibilities. There may be a problem with both the intrinsic plus extrinsic pathways and or the common pathway downstream. We don't really know. Next to this kid holding up the PT paratrooper figure whilst blurting out that APTT action sound effect, we'll illustrate a couple important acquired causes of both prolonged PT and APTT. We're talking liver disease and DIC. Alright, but before we jump into the specific coagulation disorders, what if PT and APTT are normal in a patient with a suspected bleeding diathesis? What? In that case, consider a platelet disorder, which, if you recall, is typically associated with a mucocutaneous bleeding pattern. Again, just think back to that baseball game. Ah!
Are you bleeding? There's no bleeding in baseball.
We're talking epistaxis or gingival bleeding, asymptomatic petechiae, small superficial ecchymoses, and menorrhagia. Also, bleeding usually occurs immediately after vascular trauma and is rarely delayed. Get a platelet count, which is part of the CBC. This distinguishes a quantitative platelet disorder. A blood smear is used to confirm. To identify a qualitative platelet disorder, test for von Willebrand disease and consider PFA 100 testing. Screening for von Willebrand disease include factor VIII activity, VWF antigen, and ristocetin cofactor activity. And remember that APTT can be prolonged in these patients since, von Willebrand factor stabilizes factor VIII and all. Check out our platelet disorder sketch for all the stats. You might also consider testing renal function since uremia can lead to platelet dysfunction. And finally, if you suspect a coagulation disorder, make sure to get a thorough history looking for medications that can also increase the risk of bleeding, like NSAIDs, antiplatelet agents, or anticoagulants. This is especially important to consider in that patient with a history of vascular disease, thromboembolism, or atrial fibrillation, for example. We'll cover a few anticoagulants in this sketch and remind you of the antiplatelet agents over in the platelet disorder sketch. Alright, let's continue our differentials, starting with the conditions that mainly affect the extrinsic coagulation pathway. That means PT is prolonged, but not APTT. Underneath this PT paratrooper, we'll illustrate the two biggies that fall into this category: vitamin K deficiency and warfarin administration. Vitamin K deficiency will be symbolized by this K shaped controller getting thrown to the ground as this kid rage quits in the middle of a Claude of Duty match. The vitamin K dependent coagulation factors are those that require carboxylation by vitamin K in the liver and include factors 2, or thrombin, 7, 9, and 10. And up on the screen, you'll notice that each of these factors is represented by its corresponding logo on the soldiers' helmets, representing their brigade. You've got the Thrombivers, 7 Deadly Sins Devils, 9 Lives Cats, and if you fork over some cash, the Factor 10 Fox Brigade as DLC. Anticoagulant proteins C and S are also vitamin K dependent, symbolized by the captain and sergeant labeled C and S in the background. Notice that the 7 Deadly Sins soldier is already down on the battlefield, illustrating that factor 7, part of the extrinsic pathway, has the shortest half life of all vitamin K dependent factors. Therefore, in the setting of vitamin K deficiency, factor 7 decreases first, resulting in a prolonged PT-INR and a normal APTT. During severe deficiency, however, additional vitamin K dependent factors are affected, which means you'll measure a prolonged APTT as well. Vitamin K dependent factors can also be measured. Levels will typically be less than 50% of normal in deficient patients. Vitamin K deficiency is more common in newborns because the liver is immature and cannot effectively use vitamin K. And on top of that, they tend to have low vitamin K stores. Breast milk also has inadequate levels of vitamin K. In adults, vitamin K is normally acquired through the diet, although dietary related deficiency is pretty uncommon. Because it's fat soluble and all, vitamin K can become deficient in the setting of GI related fat malabsorption disorders, represented by this brown puddle of chunky fish tank debris. Think of diseases like celiac disease, IBD, extensive bowel surgery, and cholestasis, such as primary sclerosing cholangitis and primary biliary cholangitis. In addition, pancreatic enzymes are important for the absorption of fats, and therefore fat soluble vitamins. So, diseases that lead to pancreatic insufficiency, such as CF and chronic pancreatitis, can also result in malabsorption and vitamin K deficiency. Because bacteria in the distal ileum and colon help synthesize absorbable vitamin K, broad spectrum antibiotics that eradicate the intestinal flora can also cause vitamin K deficiency. Second and third generation cephalosporins are also associated with hypoprothrombinemia and exert a warfarin like inhibition of vitamin K recycling in the liver. When it comes to treating vitamin K deficiency, you can start by simply administering vitamin K in either the PO, sub-Q, or IV forms. The method for administration will depend on the clinical scenario. However, oral is typically more effective than sub-Q, and IV is often reserved for major bleeding secondary to warfarin. Make sure you avoid rapid infusion of IV or IM vitamin K, as fatal anaphylaxis has been reported. And, of course, consider treating the underlying disorder if possible. Now that you know a bit about vitamin K's role in coagulation, let's move on to talking about warfarin, symbolized by this war video game. Warfarin is commonly used to treat and prevent thromboembolic disorders and embolic complications associated with atrial fibrillation and prosthetic heart valves. Warfarin is a vitamin K antagonist. Specifically, what we are antagonizing here is vitamin K epoxide reductase, or VCOR, in the liver, which converts vitamin K to its active form. So, down goes those vitamin K dependent factors 2, 7, 9, and 10. Eventually, that is. As we illustrated earlier, factor 7 has the shorter half life, so the extrinsic pathway is affected first, resulting in a prolonged PT. Full anticoagulation takes about 3 days as the rest of the factors are cleared from the circulation. The International Normalized Ratio, or INR, is calculated based on the PT. Its most common use is for the determination of treatment efficacy in patients taking warfarin. In general, warfarin has a weak, if any, effect on APTT, though supratherapeutic levels of warfarin may increase APTT. We know that patients appropriately anticoagulated with warfarin can bleed, but one of the biggest problems with warfarin is the potential for excessive anticoagulation, which can happen with certain medications that interfere with warfarin metabolism. Warfarin is broken down by the enzyme cytochrome P450, represented at Sketchy by a P450 license plate on a chrome bumper. In this scene, the car is broken down and dilapidated to convey inhibited cytochrome P450. Medications that inhibit this enzyme will reduce warfarin metabolism, resulting in increased warfarin levels and a supratherapeutic INR. Some of these meds include fluconazole, miconazole, voriconazole, metronidazole, amiodarone, gemfibrozil, and sulfamethoxazole, which I remember with the acronym FEMVAG. Badges? Okay, no, I don't, but I could. In addition, as we discussed with vitamin K deficiency, some antibiotics can alter intestinal flora, reduce vitamin K synthesis, and thus augment the effects of warfarin. INR can also fluctuate based on dietary intake of vitamin K. Treating the patient with warfarin associated bleeding depends on multiple factors. But for the purposes of this video, we'll discuss the treatment plan for the patient with serious or life threatening bleeding. Step 1, which is fairly intuitive: discontinue warfarin. Vitamin K should also be administered. However, full reversal may take several hours as it's dependent upon synthesis of new clotting factors. So, for serious life threatening bleeding, a prothrombin complex concentrate, or PCC, is the recommended agent for rapid reversal of drug effect. This blood product derivative contains therapeutic levels of factor 2, 7, 9, and 10, along with protein C and S. Hey, what do you know? All the vitamin K dependent coagulation factors affected by warfarin, symbolized by the characters on the screen in front of you. FFP, symbolized by these FFP fighter pilots, is another option for coagulation factor replacement. But it's a larger volume than PCC, and it takes substantial time to thaw, and it's also associated with a risk of volume overload or transfusion related acute lung injury. PCC is faster and just as effective, with fewer adverse events. So it's the recommended first line treatment for severe warfarin related bleeding. Alright, time to continue our differential. Moving on to the conditions that mainly affect the intrinsic coagulation pathway. That means APTT is prolonged, but not PT. We're going to focus on the hemophilias, which we'll associate with that sound effect on the movie poster. But first, a brief word about heparin. Heparin, represented as usual by our recurring heparin hunter character, works by binding and potentiating the action of antithrombin 3. This, in turn, inactivates thrombin and factor 10A. Now, because thrombin and therefore the common pathway are inhibited here, you'd expect both PT and APTT to be prolonged. Turns out, however, that most PT reagents contain heparin binding chemicals that block its effects. Ergo, only the APTT is prolonged. In fact, the APTT is used to monitor heparin therapy. So we've placed our monitoring binocular symbol next to the PTT poster. Anti-factor 10A activity is an alternative test used to measure heparin activity, which makes sense given the fact that heparin screws up your factor 10. To remember anti-factor 10A, just think of the darts being thrown at, if you will, this factor 10 fox. It's important to note that low molecular weight heparin, fondaparinux, and the direct factor 10A inhibitors often do not prolong the APTT. Monitoring is not necessary with these agents, but if you just can't help taking a peek, monitoring can be performed by testing for anti-factor 10A activity since they all affect factor 10A as well. Convenient. In patients with severe or life-threatening bleeding, heparin should be discontinued immediately. You can actually reverse the anticoagulant effects of heparin with IV protamine sulfate, which will protect you from bleeding. Protamine, protect. No? Of note, protamine does not completely reverse the effect of low molecular weight heparin. Alright, how about a quick game of billiards while we discuss hemophilias, which are inherited clotting factor deficiencies? Hemophilia A is the most common inherited clotting factor deficiency. Notice the A-shaped rack and next to it, a falling 8 ball. A reminder that hemophilia A involves a deficiency of factor 8. Because it's an X-linked recessive disorder occurring in male children of female carriers, We've drawn a boy here, hiding, receding, if you will, behind that X drawn on the pool table. Hemophilia B, also known as Christmas disease, worst Christmas present ever, is the second most common clotting factor deficiency. Hemophilia B is represented by the B in billiards next to the cat jumping off the table. Yep, it's that 9 lives cat again. Here to remind you that hemophilia B involves a deficiency of factor 9. It's also an X linked recessive disorder. Depending on the severity of the disease, signs and symptoms can present at any age. Nevertheless, the hemophilias are usually diagnosed in early childhood, hence the young recessive chap back there. Hemophilias can be characterized into mild, moderate, or severe based on the baseline factor activity that's present. Patients with severe disease will have less than 1% factor activity. Individuals with mild hemophilia generally only present in response to trauma or surgery, and these patients may present at an older age. Those with moderate hemophilia have a more severe reduction of factor activity and often bleed following minor injury and invasive procedures. Patients with severe hemophilia are at risk for spontaneous, severe bleeding episodes and earlier age of first presentation. The most common site of bleeding in patients with hemophilia is into the joint space. That's hemarthrosis, my friend. And just poor billiards etiquette. Hemarthrosis can cause joint pain. Recurrent hemarthrosis over time can lead to hemosiderin and iron deposition in the joint space, causing a fibrotic process called hemophilic arthropathy. This presents with chronic joint pain and decreased range of motion. With factors 8 and 9 involved, you bet your bleeding gingiva that the hemophilias are going to affect the intrinsic pathway. That means a prolonged APTT. Platelet count and prothrombin time will be normal. If you suspect a hemophilia, you can test factor 8 and 9 activity levels. This will give you the diagnosis and help you determine the severity of their disorder. Genetic testing is also appropriate for some patients, both to confirm the diagnosis and also to identify female carriers of the gene, which can be important for prenatal counseling. Alright, I know I keep bringing up that platelet sketch, but I just wanted to remind you that von Willebrand disease can look a lot like mild hemophilia, with prolonged APTT and bleeding. Why? Because von Willebrand factor is important for the stabilization of factor 8, of course. However, remember that VWD is transmitted in an autosomal dominant manner, so it'll pop up in female patients in the family history. Additionally, patients with von Willebrand disease usually present with mucocutaneous bleeding due to a qualitative platelet defect, not deep soft tissue bleeding, which is more coagulation factory. Alright, before moving on to the plan, a sample assessment paragraph to satiate your hunger for conciseness. Xavier Link is a 9-year-old male who presents with complaints of pain and limited motion of the right knee for several weeks with no history of trauma. History reveals that his maternal grandfather had a clotting disorder. Physical exam reveals a swollen right knee with a painful, limited range of motion. Labs indicate a prolonged APTT and coagulation factor 8 less than 40% of normal. This patient's clinical presentation and laboratory evaluation suggested diagnosis of hemophilia A. Plan time! Patients with severe acute bleeding should have immediate replacement with appropriate factor therapy. It's important to keep the factor level above 50% at all times during an acute bleed. That's why there are plenty of replacement 8 and 9 balls available. Patients who are at high risk for a bleeding episode or have had several prior episodes may be candidates for prophylactic therapy. So we've brought in our recurring PPX prophylaxis symbol. This involves replacing the deficient factor in an attempt to prevent future episodes and complications such as hemophilic arthropathy. These factor replacements can be from plasma concentrates or recombinant human factors. Patients undergoing an invasive procedure, such as major surgery, dental procedures, tonsillectomy, or endoscopy, may require prophylactic factor administration. However, these decisions are made on a patient by patient basis. For patients with mild cases of hemophilia A, DDAVP or desmopressin is an option, represented by this cool remote control DDAVP ATV. DDAVP promotes the release of factor 8 and von Willebrand factor from platelets and endothelial cells. If patients only have a mild factor deficiency, DDAVP can help to raise the factor level in the setting of minor bleeding or help to prepare for minor invasive procedures. Other inherited coagulation factor deficiencies of the intrinsic pathway exist, but are much rarer than the hemophilias. Although these may prolong the APTT, they're not always associated with severe bleeding like the hemophilias. Next, let's talk about some conditions that affect both pathways, including the common pathway downstream. We'll be focusing on DIC and liver disease. Don that Khaleesi cosplay and get ready for some serious LARPing, because an epic battle of darkness and demons awaits us. Disseminated intravascular coagulation, or DIC, symbolized as always by these DIC dice, is a systemic process that causes both thrombosis and hemorrhage, which is why one of the dice is red while the other is black. DIC is typically precipitated by a severe underlying condition like sepsis, malignancies, trauma, and obstetrical complications. DIC is characterized by the activation of the coagulation cascade, leading to excess production of arterial and venous thrombi in both the microvasculature and larger vessels. This is portrayed by the creepy blood clot trees clogging the red and the blue rivers, as well as the little tributaries. Long story short, activate your factors and it's thrombosis time. In the setting of DIC, excessive activation of coagulation and extensive thrombus formation leads to consumption of coagulation factors. Kind of like these coagulation fighters here who have been defeated and discarded into the game bag. Platelets are also used up, which is why this condition is known as a consumptive coagulopathy. Just consuming everything in its path. But it's not just the consumption of factors and platelets that leads to problems in DIC. There can also be excessive fibrinolysis. Just think of this fibrin tree here, getting all fibrinolysed and such. Anyways, long story short, consumption of factors, consumption of platelets, add some excessive fibrinolysis just for good measure, and it's bleedy bleedy times. As you can imagine, tissue and end organ damage occurs as a result of either hypoperfusion, thrombosis, or bleeding. So, what caused all this coagulation carnage? Well, common causes of DIC include sepsis, represented by this murky septic swamp here, trauma, as depicted by the D&D player's cast, I guess it's like full contact D&D, and malignancies, portrayed by the crab warrior, acute promyelocytic leukemia in particular, represented by his pro level shirt. Hemolytic transfusion reactions can also cause DIC, depicted by mom bringing down a transfusion of refreshing red Kool-Aid. And finally, obstetrical complications like preeclampsia and HELP syndrome can also cause DIC. The hallmarks of DIC are bleeding and coagulation. Bleeding manifests as petechiae, bruising, and oozing from wounds, mucosa, and IV sites. Though in this guy's case, oozing from spear wound sites. Alright, now about that end organ damage I mentioned earlier. The liver is frequently affected in DIC, with jaundice as one of the initial manifestations, illustrated by this angry yellow orc goblin guy. Pre existing liver disease can make the manifestations of DIC more severe, so for his sake, let's hope he's not a big fan of the meat. DIC can also present with pulmonary complications, including dyspnea and hemoptysis secondary to microthrombi and pulmonary hemorrhage. Intracranial microthrombi and hemorrhage can present as neurologic problems, including delirium and focal deficits. As DIC progresses, superficial tissue thrombosis and hemorrhagic skin necrosis can cause a rare, life-threatening condition called purpura fulminans. This is characterized by large purple skin discoloration and eventual skin necrosis. And, as suggested by the stabbed kidney shield, the kidneys are a frequently affected organ system in patients with DIC. Check for a decreased output, an early sign of kidney compromise. I think it goes without saying at this point, but because we're using up coagulation factors here, just a reminder that both PT and APTT will be prolonged. Additionally, expect that platelet count to be low, as depicted by these torn up, used plates. DIC produces a microangiopathic hemolytic anemia, also known as MAHA. As red blood cells pass through the vasculature, they're mechanically sheared by microthrombi and fibrin strands. So check that peripheral smear. Dang, they brought out the lamb's blood? That's some pro-level D&D right there. The peripheral smear will reveal schistocytes, sheared broken red blood cells. Schistocytes are also called helmet cells. On labs, look for a low fibrinogen, which makes sense considering the fact that you've got widespread clotting and therefore accelerated conversion of fibrinogen to fibrin. If a fibrin clot is one of those fibrous tree game pieces, then fibrinogen is the precursor, the game pieces in their original plastic frame, ready to be popped out. Notice it's pretty empty, however, depicting consumed fibrinogen. As mentioned previously, DIC is also associated with increased fibrinolysis, which means increased fibrin degradation products on labs, such as D-dimer. In this scene, elevated D dimer is represented by the D&D game manual on the table. It's imperative to recognize DIC immediately so it can be addressed immediately. The scenario will look something like this. Mr. Onomaha, a 70-year-old man with a history of gastric cancer undergoing outpatient chemotherapy, is admitted to the ICU for bacterial sepsis. On day 4 of his admission, his nurse raises concerns that his mental status is deteriorating and has noticed blood oozing from multiple IV sites. Physical exam reveals decreased urine output over the last 24 hours and multiple patches of necrotic skin. Labs show prolonged PT and APTT, elevated D dimer, low fibrinogen, and thrombocytopenia. Peripheral smear confirms the presence of schistocytes. Given his history, physical exam, and lab findings, Mr. Maha likely has disseminated intravascular coagulation caused by underlying malignancy and sepsis. DIC is a pretty nasty beast, and the treatment is largely supportive. The first and most important step in treating DIC is treating the underlying condition. This is really the only way to stop the ongoing coagulation and hemorrhage. Just treat it. You can further support these patients by replacing some of the consumed coagulation components. Cryoprecipitate, which contains fibrinogen, clotting factors, and von Willebrand factor, is useful in DIC patients with serious bleeding and low fibrinogen levels. Just think of this cryo ice pack here cooling down the situation. Additionally, FFP is also used to reduce bleeding in patients with elevated PT and APTT. FFP contains all the factors. Sounds useful right about now. DIC with serious bleeding and platelet counts less than 50,000 should receive platelet transfusion as well. So bring in the new plates. Alright, I bet you thought we were done. But there's one more factor deficient state to cover: liver disease. As you know, clotting factors are produced in the liver. Chronic liver disease and cirrhosis, or conversely, acute liver failure, which you can think of as really, really bad acute hepatitis, are both associated with compromised clotting factor synthesis, which is why we've included a few sunken coagulation factor figurines at the bottom of the tank. This leads to bleeding, of course. Now, labs wise, this leads to prolonged PT and APTT. A few things to note. In the setting of acute liver failure, PT becomes abnormal within 24 hours of impaired synthetic function. It might not show up right away, in other words. Additionally, because of the short half life of factor 7, PT will theoretically become prolonged first in early liver disease, just like we saw in early warfarin therapy and vitamin K deficiency. In addition to low clotting factors, liver disease can lead to both decreased platelet count and function. One cause is decreased thrombopoietin production by a dysfunctional liver, resulting in decreased platelet production. Another cause is splenomegaly due to portal hypertension, leading to increased splenic sequestration of platelets. On labs, that means thrombocytopenia. Keep in mind that thrombocytopenia is more common in chronic liver disease, cirrhosis, versus acute liver failure, though it can be seen in both. Liver disease is also associated with increased fibrinolysis, which contributes to increased bleeding risk. Increased TPA activity, which generates plasmin, in addition to elevated levels of fibrin degradation products, which themselves inhibit clotting, are thought to be at least partially responsible for this phenomenon. On labs, that means an elevated D dimer. However, the D dimer will only be mildly elevated in liver disease. In DIC, on the other hand, D dimer levels can be dramatically elevated. Also, keep in mind that the liver makes protein C, protein S, and antithrombin, which are anticoagulation factors. If these factors are deficient due to liver disease, patients can actually be at risk for increased clotting, as depicted by this clogged fish tank filter. Yep, clotting. Even though these patients may have a prolonged PT and APTT due to factor deficiency, do not assume that these patients are auto anticoagulated, so to speak. They may still require anticoagulation therapy in the setting of disease complications, such as venous thromboembolism. These patients should be evaluated on a case by case basis, and, if started on anticoagulation, should be monitored closely. Speaking of meds, in general, it's important to avoid medications that further increase the risk of bleeding, like NSAIDs and aspirin, symbolized by the fish medication with the oozing red slime. Too bad all these meds didn't help whatever used to live in this aquarium. He's in a better place now. As you can see, the labs in liver disease may look very similar to DIC labs, such as prolonged PT and APTT, elevated D dimer, and thrombocytopenia. Some clues that it's the crappy liver's fault? Well, the D dimer will only be mildly elevated in liver disease, In DIC, the D dimer levels can be dramatically elevated. And factor VIII levels will usually be normal in liver disease because it's also produced in endothelial cells, which is why the 8 ball is defying the laws of physics by floating up to the top of the tank. In DIC, however, factor VIII levels will be low. Some clinicians might even order a factor VIII level to help differentiate between DIC and liver disease related coagulopathy. The big clue pointing to liver disease over DIC? Abnormal liver labs, of course, including AST, ALT, ALK Phos, and bilirubin. A known history of liver disease or risk factors like chronic alcohol use can also be helpful in pointing to the liver as the source. Now, the transaminases may not be elevated in the setting of severe cirrhosis and synthetic dysfunction, but that's a story for another time. Check out our acute and chronic liver disease videos for the full workup. Active bleeding in the setting of liver disease is treated supportively, much like DIC. For starters, you need to treat any underlying exacerbating conditions like infection, uremia, or concurrent DIC. In acute bleeding in liver disease patients, you should give vitamin K immediately if there's any chance they have vitamin K deficiency. It theoretically takes hours for vitamin K dependent factors to return to normal, so it's not the best treatment of acute bleeding, anyways. But the potential side effects of vitamin K administration are minimal, so it can't hurt. For poorly controlled bleeding, administer cryoprecipitate to replace coagulation factors quickly. Just like we talked about with warfarin reversal, FFP can also be used to replete factors, but may not be preferred due to the larger volume load. These patients may have high portal pressures and more volume load should usually be avoided. Once again, give an infusion of platelets if the platelet count falls below 50. Thanks, Mom. And that's the end of our quest through coagulation factor bleeding. Let's quickly summarize the sketch with a quick differential diagnosis of your patient with a suspected bleeding disorder. First, get a bleeding history. The general presentation of bleeding from coagulation factor disorders include easy bruising, soft tissue hematomas, mucosal bleeding after minor trauma, hemarthrosis, and the feared intracranial hemorrhage. To wrap up the history of present illness, remember the conditions that can precipitate DIC, including sepsis, trauma, malignancies, hemolytic transfusion reactions, and obstetrical complications. Get a past medical history, looking for liver disease or kidney disease. Remember that we crammed all the platelet disorders into that DDX clipboard. A reminder to check out our platelet dysfunction sketch. That includes uremia in the setting of kidney disease. Also, look out for conditions that can cause malabsorption. Vitamin K deficiency, here we come. Get a family history. The hemophilias are X-linked recessive, and von Willebrand disease is most commonly autosomal dominant. Remember that von Willebrand disease can kind of act like hemophilia A because of that whole factor VIII deficiency thing. Then look at dem meds. Ask about anticoagulants, antibiotics, and platelet inhibitors like NSAIDs. Perform a physical exam, assessing for all those bleeding signs we discussed, as well as signs of liver disease, such as splenomegaly, jaundice, spider angiomata, gynecomastia, and asterixis. Lab time! Usually starting with the CBC, PT, and APTT. PT and PTT normal? Start thinking about platelet disorders. For a full workup, head on over to our dedicated platelet disorder sketch. Only PT prolonged with a normal APTT? Think about vitamin K deficiency. Remember that factor VII goes down first, affecting the extrinsic pathway only, and therefore prolonging the PT. In severe deficiency, however, all the vitamin K dependent factors are affected, and both PT and APTT will be prolonged. Warfarin therapy mainly affects PT-INR, not the APTT, but that should have been caught in the medication history. You never know, though. Again, supratherapeutic concentrations of warfarin can cause both the PT and APTT to increase. Remember that whole short half-life factor VII phenomenon means that early liver disease can also present with prolonged PT with a normal APTT. Though once the other factors are affected, expect both PT and APTT to be prolonged. If these conditions are ruled out, usually the search for a specific factor deficiency or inhibitor is pursued. Look for something screwing up the extrinsic pathway. Hematology stuff. Treatment of vitamin K deficiency includes giving, guess what? Vitamin K. And addressing the underlying issue. Serious bleeding related to warfarin use is treated primarily with prothrombin concentrate to replenish those vitamin K dependent factors, with FFP as a second line therapy. Alright, what if the APTT is prolonged, but the PT is normal? Think about heparin therapy, which affects thrombin, part of the common pathway, sure, but is inactivated by the PT reagent, so will only prolong the APTT. Heparin is monitored using the APTT. Anti-factor 10A activity can also be used to monitor heparin therapy. Remember that low molecular weight heparin, fondaparinux, and the direct factor 10A inhibitors often do not prolong the APTT. Monitoring is not necessary with these agents, but monitoring can be performed, if you just can't help yourself, by testing for anti factor 10A activity since they all affect factor 10A as well. Convenient. Heparin can be reversed with protamine. Low molecular weight heparin only partially. When just the APTT is prolonged, also think about hemophilia A or B, which are associated with factor 8 or 9 deficiency, respectively. That means the extrinsic pathway is disrupted. Hemarthrosis is the most common type of bleeding here. Hematologic tests usually involve assessing for the missing factor. Treatment logically includes replacement of the deficient factor, whether it's factor 8 or factor 9. DDAVP is used to treat hemophilia A as it induces release of factor 8. Fun! Remember that von Willebrand disease can look an awful lot like hemophilia A, with a prolonged APTT and everything. If suspected, proceed with the full von Willebrand disease workup, which is discussed in our platelet disorder sketch. And the grand finale, both PT and APTT are affected. Now, we already mentioned that severe vitamin K deficiency and supertherapeutic warfarin can cause this lab pattern. But then there was this nasty DIC and liver disease, which both affect the coagulation cascade broadly. What are some of the clues that point you to one of these diagnoses? Well, DIC is characterized by the activation of the coagulation cascade, causing diffuse arterial and venous clotting. MAHA will cause schistocytes on the smear. The consumption of massive amounts of coagulation factors prolongs that PT and APTT, of course. And as for the platelet consumption, well, expect thrombocytopenia. Because of increased fibrinolysis, also expect low fibrinogen and an elevated D dimer, or a DND dimer, as it were. Bleeding manifests as petechiae, bruising, and oozing from wounds, mucosa, and IV sites. All this bleeding, thrombosis, and poor perfusion leads to end organ damage, or end orc damage, if you know what I mean. Keep in mind the precipitating events that can cause DIC. Treat DIC by addressing the underlying condition. And for bleeding patients, administering cryoprecipitate or FFP and platelet transfusion in patients with platelets less than 50,000. Liver disease can also have labs similar to DIC. Besides the usual liver labs, such as AST, ALT, ALK-Phos, and bilirubin, as well as thrombocytopenia, typically in severe chronic liver disease, expect factor 8 to be preserved since it's also made by endothelial cells. And yes, there's increased fibrinolysis, but the D-dimer won't be as high as in DIC. If you've got a bleeder, give cryoprecipitate to replace factors, as well as platelet transfusion for patients with platelets less than 50,000. Vitamin K can be given as well, just for good measure. What is that?